Hello, welcome to the Grow Your Wealthy Mindset podcast, where it is all about helping amazing physicians just like you create a wealthy life free from burnout and with the financial security to practice medicine on your own terms. I'm your host, Dr. Elisa Chiang. Welcome back to another episode of the Grow Your Wealthy Mindset podcast. Today, I have a special guest, Dr. Celine Lee, who is going to talk about an issue that I personally actually know very little about. This is something that can affect people who are on expensive medication, which I personally am. I'm on a medication that theoretically costs over $10,000 a month. Of course, I don't pay that. And so this is something that really piqued my interest. Dr. Celine is a rheumatologist, so she prescribes a lot of biologicals, which we as physicians know are fairly expensive medications. So this is an issue that her patients do run into probably on a pretty regular basis. So Celine, why don't you introduce yourself further and give us a little bit more information about this copay accumulator?
Oh, sure. Yeah, thank you so much for inviting me to your show. My name is Celine Lee. I'm a rheumatologist. I practice in Utah, where the copay accumulators still exist. And as a rheumatologist, I prescribe a lot of advanced medication to treat the diseases, such as biologics and those kind of things. And many people probably heard about this expensive medication in TV commercials, and how they talk about you may pay as little as $0 or $5 for this medication. And, those any medication that it is excessively expensive, usually have some copay assistance program, thankfully, because it's very difficult for normal average person to pay for that, like several $1,000 medication.
Give us an example, like how much does a drug like Humira cost?
It's several $1,000s. The Humira is the one that actually the patent expired last year. So now we have biosimilars. But even those biosimilars are still, a few $1,000s. Some of the really expensive infusion medication can be, as you said, it could be about $10,000 per month. These are not just a little bit of expensive medication. These are not affordable without the help of copay assistance program.
Yeah, as an oculoplastic surgeon, I prescribe a medication called Tempeza, and one treatment protocol of Tempeza is over $100,000.
Wow, that's another level.
Yeah.
That's another level. Wow.
All right.
Yeah.
So why don't you continue?
Yes, yeah. Oh, yeah. I think that the most expensive one I saw was of about $40,000 to $50,000 per month. So you beat me.
Well, the 100,000 is for the whole treatment protocol, which is over several months.
Oh, I see, I see. Okay. Yeah. So we know that, there are very expensive medications and procedures out there. This copay accumulator is, at least in Utah, it was not a norm up until about 2 years ago. And I just started learning about this copay accumulator because of my patients, what happened to my patients. So she has one of rheumatoid disorders. So she was getting one of this biologic medication, and it was fine. She was able to use a copay saving card, and the copay saving card helped her to pay the copay, and that money counted toward her deductible. So she was able to meet the deductible, and after that, her insurance company started covering it, and she paid a little bit of copay co-insurance, and then she was able to afford the medication. But one day she just came here, and there was like summertime. It's probably around the time that her copay card expired, and she just came to me, and she got billed about more than $1,000 for the same medication that she was able to get it just with $5. So I had to dig into that, the case, and I learned that she had copay accumulator, which means that the money that she paid using the copay saving card, none of the money counted toward her deductible. So I want to just make a very simple like example. Let's say somebody have $7,000 deductible, which is very common for employer sponsored high deductible plan. It's very common to have $7,000 or $8,000 deductible. And let's say somebody have $7,000 deductible and medication is $1,000. And let's say the copay saving card included about $5,000 in the card. So before, without the copay accumulator, just a patient just use the copay card and just give it to the pharmacy, and the pharmacy will just charge the copay card, and then the money will be just deducted from the copay saving card. And then, so let's say, first month, because the patient did not meet the deductible, the insurance company will not pay anything until the person meet the deductible of $7,000. So the patient will have to pay the full amount of the medication, and the patient can just use the copay saving card, and the $1,000 will be deducted from the copay saving card, right? So you pay $1,000, and the second one $1,000. So until the copay card is exhausted, which contains $5,000, the patient will just use the card to pay for that. Some card will have very little like a copay after the copay card. So patient will maybe pay like $5 or $10 or $35, something like that, but it'll be a very small amount. So patient just pay like that. And after the $5,000, the copay value, copay card value is exhausted, the $5,000 will be count toward the deductible. And then the patient just need to pay $2,000 more themselves, and then they'll meet the deductible.
So let me just make sure I understand this. So the drug is $7,000.
No, in this example, the $7,000 is a deductible of the patient.
Oh, right. Oh, right. You're right. The 7,000 is the deductible. The drug cost how much?
Drug is $1,000.
Oh, the drug is 1,000. Okay. And the insurance isn't covering the drug at all because the patient hasn't met the $7,000 deductible.
Yes. There are some exceptions. Actually, I forgot to tell you about this disclaimer, because I'm not an insurance agent, and this is so complicated problem. I'm triple boarded in dermatology, rheumatology, and internal medicine, but I'm telling you, this is much more complicated in any science about Krebs cycles or whatever. This is more complicated in medical school, because change it every year too. Krebs cycle does not change every year, right?
No, it doesn't change at all.
Yeah, so I'm not an insurance agent. I'm not from copay saving program, and this is different according to the insurances, what kind of medication you're using, what state you're living in, and what kind of employer you have, and if the employer self-funded or not self-funded. It's according to many different factors. It's all different. So please. Just this is of general information about copay accumulator, but for your individual cases, please call your insurance company and the pharmacy. And if you're using expensive medications, they usually have patient support from the pharmaceutical company. So please talk to them to know your individual cases, because this is really different according to many different factors. So there are some exceptions. So for example, I understand at least here, I know some diabetes patients who does have a copay accumulator, but they don't have to pay the full amount of insulin because insulin is covered by the insurance from the beginning, even though they did not meet the deductible. So there are some exceptions like this according to which medication we're talking about. But I know that in Utah, there's some news articles that chemotherapy for cancer was not covered by the insurance company because the patient did not meet the deductible. And the patient could not pay that really high deductible plan, and she could not get the chemotherapy for her cancer for a while. And this was actually made into a news article in the local TV station. So according to which medication can be different. But when we go back to the previous example, let's say.
Sorry, I just want to stop you once again to clarify. So my experience with health insurance and medications is that usually there's a copay for generic, there's a copay for brand name, and then there are specialty drugs where they'll cover, let's say, 70% and you have to pay 30%. And a lot of these more expensive drugs fall under that. Mm-hmm. So what you're saying is there's also a category of drug where the insurance basically will just pay nothing until you actually meet your deductible.
In Utah, for rheumatologic medication, in my patient experiences, they didn't pay anything until they meet the deductible. And because this medication, but again, this is a different according to the states, which medication we're talking about, which insurance the individual person has. And there's some exception like insulin for diabetes patients.
Got it.
Yeah, that's the reason why the disclaimer was really important, because it's really there's several thousand different policies in United States. It could be several thousand different thing about this. according to which medication we're talking about. So we really, the patient need to call their insurance company to learn the specifics about their policy. But for my experience, for rheumatoid diseases, the patient so far, if they don't have copay accumulator, then they can just use a copay saving card and they can pay using that card, and they will have to meet a deductible more faster. And after that, the insurance company start covering it. But I have actually some patients who had to stop the medication, and I'm trying to kind of find a way so that they can continue the treatment. But they have to stop the medication because they could not afford the initial medication price. For example, if somebody deductible is like $7,000 and the medication is like $6,000, and if they cannot pay the $6,000, if they don't have a mean to put that money somewhere, then it can be difficult for that person to pay $6,000 just out of nowhere. If that person have some like short-term loans such as credit card, things like that, they can just put it there for the time being. But some people cannot have that credit limit of the several $1,000s, so it can be a problem for some patient. And I do have some patients who told me that they cannot afford to pay that initial several $1,000s.
So with the copay card, there are some insurances where if they use the copay card, the amount that the copay card is paying actually does go towards the deductible.
So that was how it's supposed to do. So anybody who have commercial insurance, because Medicare or Medicaid patients are not allowed to use copay saving card. So copay saving card is only allowable for commercial insurance patients. So, but anybody who have commercial insurance usually can use the copay saving card, and the money that is loaded in the copay saving card, and they use that card to pay for the medication. That payment traditionally counted toward their deductible. So they only pay about $10 out of their own pocket. The money they pay using the copay saving card, if there was like $1,000 for this medication, that $1,000 will count toward their deductible, even though that was from the copay saving card. So that's how it used to be when there was no such thing as copay accumulator.
Okay, great.
And with this copay accumulator, now the money is not count toward the deductible. So let's say somebody have, again, when we go back to our example, $7,000 deductible, and let's say drug is $1,000, and the copay card contains $5,000 allowance. Then before, that person just pay for that $1,000 drug using the copay saving card. So pay $1,000, $1,000, $1,000, $1,000, $1,000, and then we'll use up that $5,000, right? Then that money was already count for that $7,000 deductible, so there's only $2,000 left. Then the patient themselves need to now pay $2,000 more to meet the deductible, and then insurance company will start covering it, and then there will be some co-sharing. So like you need to pay still 20%, then it'll be $200 until they meet their out-of-pocket maximum.
Got it.
So yeah, then the patient ended up paying the $2,000 and then a couple of $200 until they meet the out-of-pocket maximum. So it's not like the patient have to pay the $7,000 from their own pocket. So that's how it used to be in the good old days.
So in this case, basically, the insurance card has $5,000, so the cost of the drug is $1,000. So they basically have 5 months to save up to pay for months 6 and 7, where they'll pay $1,000 each those months. And then after month 7, they'll pay like $400 for their percentage of the copay till they get their out-of-pocket maximum. And then at that point, they would pay $0.
Yes, yeah. So that's how it used to be. But with the copay accumulator, it means that none of the money that the patient paid using the copay saving card will count toward the deductible. So this is actually, when you think about it from insurance company's perspective, it's really good for the insurance company because they don't have to pay for the medication for a very long time. So let's say, again, let's go back to this example. Let's say the deductible is $7,000, drug is $1,000, copay saving card have $5,000. The patient will just pay using the copay saving card $1,000, and then just kind of $5,000 is exhausted after month 5, right? But the problem is none of the payments counted toward the deductible, and the patient still have $7,000 deductible still left, not touched. Then now patient after month 5, there's no money left in the card, right? Now the patient have to pay for the money themselves until they meet the $7,000 deductible. So you start from the ground zero. So the patient will have to pay $1,000 for 7 months to meet the deductible, right? And then the patient now have to pay $7,000 total. And what happened to the insurance company? The insurance company paid $0 for 12 months because first 5 months was paid by the copay saving card, and the next 7 months was paid by the patient themselves. So the insurance company paid $0 for that $1,000 drop because basically the patient and the pharmaceuticals copay saving card paid everything, and insurance company saved a lot of money. And this is a reason why, obviously, understandably, they are for-profit companies. They probably want to do this, right? But it kind of defeats the object of having copay saving card in the first place, because the whole reason why copay saving card it exists is because to help patient to pay copay, not to give insurance companies some break, not paying for the medication, right? So the now patient have to pay $1,000 every month for one medication, which is a lot of burden. It's for many people, this will be as expensive or more expensive for their mortgage or rent. At this point, many patients will stop the treatment because they just simply cannot afford $1,000 medication on top of the premiums they need to pay, the rent, grocery shopping and things like that. And many patients will have to just stop the treatment because they cannot afford it. And this really defeats the object of having the copay saving card, because copay saving card exists to prevent that problem, right? So understandably, patient group made a lawsuit about this copay accumulator program in 2022. I think the diabetes patient group and patient with HIV, they made a lawsuit together in the District of Columbia Court. And on September 29, 2023, so just last year, September, the court ruled that the insurance companies cannot apply the copay accumulator to a brand name drugs that does not have alternative generic versions. So, which is really good. It's really good that the court actually say that, you cannot apply this copay accumulator for those medications, because those medications are the one that is several $1,000s. They're expensive ones. For example, like Norvasc and amlodipine. Norvasc, I don't know if Norvasc still have the copay saving card or not. Probably not. But if there's a cheaper alternative like amlodipine, then it doesn't apply to those medications. So, they can have copay accumulator for those medications. But something like, Humira, which is like probably about several $1,000s, and, copay saving card existed for those medication, and copay accumulator cannot apply to those medications. So if the patient use copay saving card to pay for that medication, that payment made through the copay saving card should count toward the individual deductible of the patient, so that it can help the patient to meet the deductible and meet the out-of-pocket maximum, so that they can continue to take the medication without interruption. So that's what the court said on September 29, 2023.
What happens with the medications where the brand name's expensive, but the generic is also almost as expensive?
Are you talking about like biosimilars?
Yes.
Yeah, so biosimilars is actually because FDA said biosimilars are not same as a generic. So you're right. The Humira biosimilars, they're still expensive. They're only about 20% cheaper than the brand name. But biosimilars are not counted as a generic version. So biosimilar actually have their own copay saving card, a lot of them. Maybe not all of them, but a lot of biosimilars have their own copay saving card, and they are and by the court law, the ruling, if somebody used the copay saving card to pay for the biosimilar, that payment should count to the individual deductible because they are not considered as a generic.
Okay.
They're not bioidentical, they're biosimilar. So they're technically not exactly the same medication. And that's what the FDA definition is. So far, as of May 2024, biosimilar is not counted as a generic, but it can change in the future. But right now, it's not considered as a generic version. But there's a catch though. That court ruling that came out September, the patient group, this I just kind of read about this, I follow these articles, the news articles about, how this is panning out, because this is still changing story because the ruling is so new. It only came out last September, and the patient group asked the court to clarify about that ruling. And in December 2023, the court clarified that the copay accumulator can only apply to the medication that have generic alternatives, but for medication that does not have cheaper generic alternative medication, they cannot apply the copay accumulator to those medications. However, this is not enforceable. That's what they said. And I don't know exactly what that means, but it sounds like they clarify that the copay saving card payments should come to a deductible, but that's not enforceable. And court said if there's more lawsuits or more kind of legal actions coming in, and they might change their stance. But this is as of like 5 months ago. And I did not hear anything after that. And what I do know is in Utah, it still exists. Our states tried to make it illegal in our 2024 legislation session, but that law didn't pass. So I still have patients who have copay accumulator and who still need to pay several $1,000s in January and February because they did not meet the deductible and they cannot use a copay saving card to meet the deductible. So that ruling didn't make much change. That's what it looks like. And there's a many patient advocate groups that try to pass the Help Copays Act. So it's HELP, Copays Act. And this is a bill that they try to pass where that the copay accumulator will be banned permanently in the United States. But that bill obviously didn't pass yet. So we'll have to see what happens in the future. But as of now, the copay accumulator still exists. And there are actually 19 states that made it illegal in state level, which is good. And this can just kind of quickly say which are those 19 states. And this is as of summer of 2023. Could be some other states that made it illegal in 2024 through their legislative sessions. But this is the list as of summer of 2023. So in Arizona, Arkansas, Colorado, Connecticut, Delaware, Georgia, Illinois, Kentucky, Louisiana, Maine, New Mexico, New York, North Carolina, Oklahoma, Tennessee, Texas, Virginia, Washington, and West Virginia, and Puerto Rico, these states made it illegal in their state level. So people who live in these states, they are in a better luck. They may not have the copay accumulator because their state law banned copay accumulator. But there's a catch. This state law does not apply to self-funded employer-sponsored insurance. So if the employer is really large and their insurance is self-insured, so it's a self-funded insurance, so that's only applied by federal law. They don't get applied by the state law. So really large employers, self-funded insurance still may have copay accumulator, even though that people, you are in one of these 19 states. So, I think it's good to know about this because, even though that you're living in like New York when there's no copay accumulator, but you may still have some family members or friends who are living in unfortunate states. Here in Utah, it's still here. Yeah, so I think it's good to know that there's a copay accumulator and just look at the what kind of policy you have, especially if you're about to start a new expensive medication. There's some hope though that I was able to help my patient, and this is for doctors. Yeah, I know that your audience is more doctors, and I have some doctor patients. And doctors are not with money. We're still, those medications. Nobody can really afford a medication like $7,000. Yeah, with our own pocket, right? And nobody can. And this patient who have like a deductible like $8,000, $9,000 when their medication like five, six, $7,000, it's really difficult in January because you cannot pay that money because it's too expensive. So I was talking with many people about how we can help patients to afford those medications, and I learned that if the patients pay just somehow just kind of come up with that initial fund, they could take some short-term loan like a credit card, for example, just kind of paid themselves using their money, and then if their copay saving card money was not touched and they still have fund available in the copay saving card, then because the card exists to pay to help the patient pay for the medication. So if the copay saving card still have some money left, and if the patient paid their own money to pay for the medication, then the patient can tell them, oh, I paid this much money to pay for this medication, then they can get the reimbursement. I heard that the patient can get help. Still, it's a problem that how can they, will they come up with the money of like several $1,000s in January? That's still a problem. If they pay using their own payment method, using their own fund, as long as there's money left in the saving card, they can send a receipt and there's some paperwork, there's some reimbursement form and those kind of paperwork thing, which is kind of cumbersome. But as long as they do that processes and they can reimburse the money to the patient as long as there's some money left in the copay saving card. And I was able to see that some cases where they have no way that they could afford this medication for themselves, but they were able to kind of come up with some money in January and they got the reimbursement. And that way they were able to afford the medication. And this is, because I'm a rheumatologist, I only know about rheumatology medications, but I think that the pharmaceutical company probably has a similar program for other medications. So I don't know your ophthalmology medication or the GI medication for Crohn's disease, ulcerative colitis, or so I think there'll be a similar program. So if you are taking one of these expensive medication, you may need to talk to your insurance company to see if you have a copay accumulator or not. And maybe you can talk with the copay saving program people to see if they have some program like reimbursement, something like this. And not all pharmaceutical companies have the reimbursement policy, but they some do. And if they do, it can help the patient a lot.
Yeah, I think in ophthalmology, I know that there is a medication, Lucentis and Eylea, and each dose is, I don't know, somewhere around 3,000 to 4,000, and it's usually every 6 weeks. So I'm sure every specialty, well, maybe not every, but a lot of specialties do have some medication that is expensive for their patients, and there's some kind of coupon program or these copay cards.
Yes, yes. And what's important thing is that reimbursement only works when there's some money left. So the first patient who kind of alert me about this copay accumulator. So what happened was she already used up the copay saving card money already in spring. And that when it came summer, the money was exhausted. And because none of that was counter deductible, now she had to pay the full amount herself. So if she had not used the copay saving card in the spring, she could have, just pay for herself and then got the money reimbursed. So it's really important that the copay card fund is not, still there, so not touched. If someone want to, explore about this reimbursement route to pay for their medication, because the copay saving card usually come with limited fund. It's not like a bottomless pocket. It come with some limitations, some certain allowance, and once that money is exhausted, there's no way to get the money back until the next calendar year. Or according to the program, sometimes it's 12 months, but a lot of them is the calendar year. So, but it's only for 12 months. And so once the money is exhausted, then you cannot get the reimbursement because there's no money left to reimburse you.
Yes. So this is where it's really important when you first get on the medication or in January, you find out about your insurance. Is there this copay accumulator clause in the insurance policy so that you reach out to whoever's doing the copay card to find out, can I get reimbursed, so that you never use the card at the pharmacy or wherever you're paying for the drug, that you pay for it with your own cash means or using your own personal credit card and then applying for the reimbursement, because now you still have value on that copay card.
Exactly, exactly. That's very important. Yeah, very important. Like either when you first start the medication or in January when it's renewed. Yeah, it's really important. Yeah.
Yeah. And so this is really great to educate. Again, yes, my audience for this podcast is mostly physicians. And so as physicians, when we are prescribing these medications, to know about this possibility and hopefully be proactive about it instead of having our patients come after they've used up the cards. And now there might be not really a way to help them.
Exactly. Yeah, I'm very proactive about educating this to my patients because if they get bitten by this copay accumulator, then there's really not much I can do other than, because they really literally physically financially cannot afford the medication and it impacts the treatment for their disease. So it's really really close to the real world problem about how can they afford the medication. So I'm very proactive about educating this to my patient. And one thing that I kind of what I noticed is when I was reading the reimbursement form from some of the pharmaceutical company, that paperwork part when patient tried to get a reimbursement, there's some like a warning kind of statement saying that, oh, if you use HSA or FSA or any of those kind of tax exempted money to pay for the medication yourself upfront, then they cannot reimburse the money.
Oh,
And I don't know, it could be maybe associated with some kind of tax implication from the copay saving card, I guess, but I'm not quite sure. But I read several those reimbursement form, and it says that they cannot use the HSA, FSA money to pay for the medication themselves. When they first pay for themselves, they cannot use those tax exempted dollars.
yeah. So it sounds like what's safest is to just pay with your own personal means,
Yes.
cash or credit. And then, because if you have an FSA or HSA, they will always reimburse you if you submit it.
Mm-hmm.
So it's probably better to just always pay cash up front and then figure out how you're going to get reimbursed, whether it's going to be through a copay card or through your FSA or HSA.
Yes, yes. Because if you pay for with the HSA, then HSA can reimburse you, but that's still your money that was in the HSA account, which you paid, right?
Right.
Yeah, so it's not reimbursed by the copay saving program. It's just you basically you are reimbursing yourself from your own bank account. So yeah, so kind of be careful, and again, because it can be different all the different pharmaceutical company or medication. So it's the best way to is to ask the copay saving program of your medication and ask them, oh, can I use those things? But my understanding is majority of pharmaceutical companies says that they cannot use HSA or FSA. Yeah.
That's a good point. Yeah, this stuff is so complicated. I mean, I know personally, like I said, I am on expensive medication and it recently went generic, but the generic is not that much cheaper than the brand name was. But that did change the whole coupon program. And, even as a physician, it was very complicated for me now as the patient to figure out how I was going to get this expensive medication paid for. So the way my insurance works is that it pays 70%, but my 30% is still over $3,000 a month. And so there's a coupon program to help me pay that down. I mean, even as a physician, I mean, could I come up with $3,000 a month? Yes. Did that significantly impact my life? Yes.
Yes, yeah. The $3,000 is majority of people, that's much more than the people's mortgage.
Right.
Yeah, and much more. Like it could be like two or three times more than their mortgage.
Yeah, it's more, 3,000 a month is more than any mortgage I've personally held. So
Exactly, exactly. Yeah, and it becomes more complicated when we talk about infusion medications, and that's the part that I still don't know because I was asking the infusion centers and I could not get a clear answer. Because what about this infusion medication that is infused by the infusion center? And that one I still don't know. I just have to ask my patient, just ask the infusion center's billing department, and also ask the pharmaceutical companies copay saving program and work with those two parties about what to do, because that's the one that I still don't know how the patient can get help. And because in Utah, I can only speak about my states and my experience with my patients and my medications, right? But I did not have much of problem of accumulator until last year. It really exploded this year. So a lot of my patients who did not have the problem until last year now have they have this problem. A lot of my patients are getting the injectables, so the method I told before worked, for them. They paid upfront themselves using the money that is not HSA or FSA, and they were able to get the reimbursement after doing all the paperwork. But infusion medication, so this is kind of whole different route, because that one the billing is different. It's done by the infusion center. So if you're taking any like expensive infusion medication such as MS medication or the for like rheumatoid or lupus, like Remicade, or like those kind of medications, then you may need to just speak with the infusion center's billing department and the copay saving program people, because they're the one who will know in and out about what to do. I'm telling you, I would rather, do the medical school again than that was more simple, because the science, it doesn't change, right? But this thing is very complicated. It's very difficult for me, and I cannot even imagine that how complicated it'll hit the patient, when it's so complicated for a healthcare professional like us.
Yeah, it's true. And honestly, trying to figure out healthcare and healthcare expenses, I feel like is the hardest part of figuring out retirement, and especially early retirement. Because at least in retirement, at age 65 or 67 or whatever it is, when you qualify for Medicare, you can kind of know what entity Medicare is going to cover. But if you retire early and now you're buying on the healthcare exchange, things like this could really creep up and cause financial disaster, depending on what your plans were for what you thought you would be spending in retirement and what actually ends up being the case, depending on what health issues you have or what health issues develop.
Yes, exactly. And because your audience probably financial savvy, because they're listening to a podcast, when they kind of thinking about their retirement plan, and some of them might want to retire early. Some people just kind of fear of retirement because of this healthcare insurance problem, because they are not sure what's going to happen. And even with the Medicare, so Medicare have some positive change, where that the Medicare Part D, the patient out-of-pocket payment, now they have a cap. So there was no cap, as my understanding is. Well, again, I'm not a Medicare insurance agent, so please consult with your Medicare insurance agent. People could pay just kind of that co-sharing for without any limit, but my understanding is there's a limit now. In 2023, it's 3,300. So patient cannot pay more than that, which is good. After that they pay 3,300, then they should not pay anymore for their medication covered by Medicare. And in 2025, no, so that's 2024, this year to 3,300. Next year, it'll become 2,000. So Medicare patients, now they just pay the cap of $2,000 for their medication covered by Medicare. Then they don't have to pay. And I'm not sure that, again, please consult with your agent, but I'm not sure if this only applies to Medicare Part D or for general, but Medicare Part D patients, now the cap amount of money that they'll spend to pay for the medication will be $2,000 from next year, this year to 3,300.
Yeah, I feel like even Medicare is getting more complicated because a lot of my patients are Medicare patients, but now with all these Medicare Advantage plans, I really can't accurately advise patients on how much they're going to end up paying because it depends on what their specific Medicare Advantage plan covers.
Exactly. Yeah, it's I would rather do 12 different Krebs cycle memorization than, I would rather memorize all the cytokine pathway than, looking at all the, I mean, there's so many like there are thousands of different policies, and according to who sponsored it, where the patient bought the plan from, it's all different. Yeah, and so when I ask the patient to ask them to the simulation to kind of give you some estimate about how much of the out-of-pocket cost for the patient, sometimes the pharmacy or the infusion center will tell them, oh, we can only do that after we submit the claim. So only after the service is rendered and only after the claim is submitted, then they can tell the patient how much it was, after fact. And then patient is hooked with that debt, and they don't know how much that'll be. I think some are better than, giving that information than others, but a lot of times my patient told me that they had difficulty in getting the estimate, how much they'll pay when they have Medicare Advantage plan, or they have some secondary insurance. They often could not get that information until they actually get the bill from the pharmacy or the infusion center. So it's kind of not very transparent.
No, it's really not. I know I've called my insurance company, make sure that something was covered, and I can find out that it's covered, but it's still hard to find out how much I'm going to end up paying out of pocket.
Yeah, very complicated.
Well, thank you so much for coming on and explaining this copay accumulator, which if it doesn't affect us or our family members, could certainly affect our patients.
Yes. I'm really hoping that the Help Copays Act will pass, the bill will pass so that this will not be a problem anymore. But if somebody wants to know more about this copay accumulator, there's a great resource. You can just Google copay accumulator, and there's a website. It's actually a Crohn's disease patient website, a Crohn's and Colitis Foundation website. They have pretty well explained, and they have some helpful link. So if you want to know more about this problem, then you can just go to that website, and you can get some information there too.
Thanks for giving a place where the listeners can find out more information.
Yes.
Any last words?
Yes. My last word is, if you're living in the States, where the copay still exists, which is all other states other than those 19 states, which is more than 50%, right? Please contact your representative and senators and ask them to look at this problem, because this really impacts the average American's life. When there's so many advanced technology coming out, but if people cannot use it, what's the point, right? If people cannot use it because of the financial obstacles. So talking to the representative and senators and ask them to do something about it, I think it'll really help. The more people know about it, the more we make our voice heard. The representative and senators, they will listen to us. So they'll kind of make some policies so that a patient will be able to use their copay saving card to pay for the medication without worrying about they'll hit by that several $1,000s bill, in the middle of the year. So please contact your representatives.
I love your last point. We definitely have to see some changes in the way the healthcare system is in the United States. And the way to do it is to legislate it. And that really means reaching out to our congressmen, our senators, and really demanding change.
Mm-hmm. Yeah, exactly.
Well, thank you so much for being a guest. I've really enjoyed having you. And thanks to our listeners for listening to the Grow Your Wealthy Mindset podcast.
Thank you.
If you enjoyed this episode, I would love it if you could share it with your friends and colleagues. And now for the disclaimer. I am not a certified financial planner, accountant, or attorney, and nothing I say should be construed as professional investment, tax, or legal advice. This show is primarily for your education and entertainment. I am a physician, but I'm probably not your physician. So if you need any medical advice, please contact your own physician. Thank you.